Welcome everyone to the fourth and final installment of our first QA Forum of 2022. I'm Dr. Michael Novick, the Director of Education and Associate Director of Quality Assurance for vRad. Today we're going to discuss anoxic brain injury or hypoxic ischemic encephalopathy or global hypoxic ischemic injury. This entity goes by several names and is one we see frequently during our QA review process. Here is our accreditation statement. And here are the learning objectives for this lecture. Our first patient is a 37-year-old woman with altered mental status, unknown cause. We'll begin with the axial images from a non-contrast CT scan of the brain. I chose this case for the conspicuity of the findings. We'll see some more subtle cases later. Here are the coronal images from the same study. We don't always have a corresponding MRI, but we do in this case. The diffusion weighted sequence. And the corresponding ADC map. Let's discuss the findings. First, we have the hallmark loss of gray-white differentiation diffusely with associated sulcal effacement. Apparent increased attenuation in the subarachnoid spaces known as pseudo-subarachnoid hemorrhage. Diffuse cortical hyperintensity on the diffusion-weighted images. With corresponding dropout on the associated ADC map. So our diagnosis is, of course, anoxic brain injury. Most cases will not have findings this conspicuous, as we'll see going forward. Let's take a few moments to review the findings of anoxic brain injury, but before we do that, I just wanted to mention that if there's one message you take home from this lecture, let it be that clinical history in these cases is key. In children, this is most commonly going to be seen with drowning and asphyxiation. In adults, it's going to be cardiac arrest patients. So if you have a case where you're mulling over whether or not to call anoxic brain injury, pick up the phone and give the referring clinician a call. They're almost always going to have a clinical history that's going to guide your diagnosis. As we mentioned, anoxic brain injury has several other names. These are a couple of them. I've heard it called global ischemia as well. And the overwhelming majority of these patients will have had a recent resuscitation attempt, even if we don't necessarily always get that information in the provided clinical history. Almost all these patients will have a non-contrast CT scan first. And the classic findings are diffuse cerebral edema with loss of gray-white differentiation, with associated sulcal effacement. This can sometimes make old brains look young, so make sure you take a look at the patient's age in every case. The so-called reversal sign, which is sometimes seen in the first 24 hours, is a bit less common. This results from reversal of the normal attenuation of the gray and white matter, and it's felt to be due to partial obstruction of venous outflow due to the increased intracranial pressure from the cerebral edema. You'll sometimes see what's known as the white cerebellum sign, which is apparent increased attenuation of the cerebellum due to the diffuse cerebral edema. Pseudo-subarachnoid hemorrhage, which we saw in our case, is felt to be due to engorgement and dilatation of the superficial venous structures, also from increased intracranial pressure. And finally, you may see prominent basal ganglia hypoattenuation. MRI is generally not necessary to make this diagnosis, but if you're fortunate enough to have one, these are the findings to look for. Diffuse restricted diffusion, as we saw with our patient, and occasionally T1 hyperintensity due to laminar necrosis. I'm going to focus much more on the CT findings during this lecture because that's frequently all we have, and it's frankly all you really need to make the diagnosis. Our next patient is a 51-year-old woman. The history is look for cerebral edema, which I assume is code for the patient is unconscious. Once again, we'll begin with the axial images from a non-contrast CT scan of the brain. Remember the findings we just discussed and be on the lookout for those. As always, you can pause the lecture at any point if you want to scrutinize a particular area or finding. The coronal images from the same study. The findings in this case are a bit more subtle. There is diffuse loss of gray-white differentiation with associated sulcal effacement. Recall that this patient is 51 years old. And in this case, we have the prominent basal ganglia hypoattenuation. And our diagnosis is again anoxic brain injury. I'm certain if you'd called the referring clinician for the last patient, they would have given you appropriate clinical history. In this case, we were fortunate enough to have it. This is a 43-year-old woman, status post-cardiac arrest. The axial images from a non-contrast CT scan of the brain. The sagittal images from the same patient. I'm sure I'm going to sound like a broken record here for the next few minutes, but that's by design. In this case, again, we have the diffuse loss of gray-white differentiation with associated sulcal effacement. Pseudo-subarachnoid hemorrhage. And on the sagittal view, low-lying cerebellar tonsils and crowding of the foramen magnum. Hypoxic ischemic encephalopathy. Another case here with the typical clinical history of cardiac arrest. This is a 63-year-old woman. The axial images from the non-contrast CT scan of the brain. Not quite as much sulcal effacement here. The findings a bit more subtle. but the clinical history should really lead you in the right direction this time. On to the coronal images from the same patient. You could certainly argue that the findings are more subtle in this case, and if you didn't have the clinical history of cardiac arrest, you might be less inclined to call this outright, but a quick call to the referring clinician would clear all that up. There's less sulcal effacement in this case, probably due to the patient's underlying age-related volume loss, but this is nevertheless consistent with global hypoxic ischemic injury. Next up is a 54-year-old man, once again with that typical history, status post-cardiac arrest. Let's review the axial images. No need for the coronals in this case. I think the most conspicuous finding here is the hypoattenuation in the basal ganglia. More inferiorly at the skull base, I hope I can convince you there is some pseudo-subarachnoid hemorrhage. I wouldn't necessarily call this loss of gray-white differentiation, but there is some subtle cortical and subcortical hypoattenuation. Consistent with anoxic brain injury. This is more consistent with the typical clinical history we get. Our next patient is a 61-year-old woman with decreased alertness. The axial images, the findings in this case are quite striking. We again have the symmetric hypoattenuation in the basal ganglia. Diffuse sulcal effacement, recall the patient is 61 years old. And in this case, the impressive reversal of gray and white matter attenuation. In this case of anoxic brain injury. This is a good reference article that reviews some of the things we talked about today. I used it when preparing this lecture. I hope most of this has been just a nice review for all of you. And remember, if there's any question, if the findings are subtle, if you're just not sure, a quick call to the referring clinician is very useful in these cases. Thanks again for joining me. We'll see you later this year with our next QA Forum series.